Good evening, everyone, and thank you ever so much for joining us. Warm welcome to this EWMA TVS webinar. My name's Nikki Stubbs, and I work currently as the clinical project lead pulling together some integrated wound clinics in Leeds. And my colleague, Kate, who you can also see on the webinar, is currently working as a clinical wound specialist, and she'll talk a little later about her redeployment during COVID-19. Just to let you know, the webinar will be recorded, so you'll be able to watch the video recording on demand, and it'll be available on the website within the next few days. You can also request a certificate of attendance if you wish, for both the live participation and via the on-demand version. And you'll do that via the EWMA website. It's really important to let you know that this is a question and answer webinar, so without your questions, it might be a little boring. So please do enter questions into the question pane available to you. And you can enter that question at any point during the proceedings. We'll start with a short introduction of a few slides, but you can start entering your questions into the question pane as soon as you wish, and we'll deal with those chronologically. Once you've typed in your question, if you have one, it would be useful if you could include the country that you're based in. So we'll start with an introduction now, and we'll try and answer as many questions as we can. So as I say, my name is Nikki Stubbs, and I work in Leeds. I've worked in tissue viability for over 20 years, and I'm currently working, as I said, to develop and deliver some integrated wound clinics, which take patients from primary care, GPs, and from community settings such as the neighbourhood teams and the district nursing teams. In terms of COVID-19 for us, it's actually been pretty much business as usual. We asked right from the outset what was expected of us once we went into lockdown in the UK, and our Executive Director of Nursing was very keen that we maintained the service for as long as we possibly could, and that's what we've done. I think the real change for us has been that we've extended our treatments from purely providing wound care to include other treatments such as catheterisation, line flushes, peg care and some injections. So really the challenges I think for me have been around maintaining data collection, communication in a number of ways really. I think particularly with the team, because they felt very isolated because they're working in a clinic on their own, socially distancing, and so therefore aren't working alongside other colleagues in the clinic room. And one of my colleagues says today is she comes to work, she goes home, and and all she does is work or walk, and that's pretty much what people feel like, I think. So it has been quite challenging for the team. I think the other communication issue has been around making sure that people are aware that the clinics are still continuing, because so many of the clinics in general practice have closed and many of the patients are having to self-care or get support from a telephone conversation. I think there's been an assumption that our clinics weren't running. So we have seen a significant dip in attendance actually, which is just starting to improve as the communication gets through. There's a lot of fear, as you might expect, and trepidation around whether or not, patients coming to the clinic have got COVID-19, the patients coming into the clinic, are the staff using the right PPE, have they been tested, what about the reception staff, because they might be coming into a general practice that they're not familiar with. So that's been quite difficult. I think some of the other challenges have been around travel. So I've certainly made sure that I wear my uniform at all times. Sometimes I wear mufti to work, but it's been easier so that when you're out in your car, you're less likely to get stopped and challenged perhaps for unnecessary travel. And of course, change is always difficult, and so some of the changes that we've had to make in the clinics have been, difficult for patients and for the staff concerned. So these are a couple of resources that I found really useful during COVID-19. So there's a dedicated page on the Tissue Viability Society website that's dedicated to COVID-19. And for those of you that work in the community, the Queen's Nursing Institute has got some really good information regarding the COVID-19 impact on community-based services, including care homes and practice nurses, as well as district nurses. Okay, so just before I hand over to Kate, just a reminder that tomorrow there's also another webinar with two outstanding individuals in the sphere of leg ulcer management, so Alison Hopkins and Christine Moffat. So it's just as a gentle reminder, if that's something that you might be interested, that you can also log into. I'll just hand over to Kate now.
Thank you. Hello, my name is Kate Williams. I'm a community tissue viability nurse or wound clinical nurse specialist. I've worked in tissue viability for 13 years now, and I'm currently in Leeds. So COVID-19 for us, it's been challenging. It still is challenging. Our team has been redeployed into the community neighbourhood teams. This brings with it advantages, but also disadvantages. One of the things which has been most rewarding is supporting patients and families with self-care. So there's patients and family members who are loving self-care. They have delighted to be asked. They couldn't wait to be asked, and they are doing a fabulous job. There's other family members who are a little bit more reluctant. We could encourage them. They have taken it on and they've done a fabulous job, but they were much more reluctant. But as things improve, they feel more empowered and they feel supported. And so that group of people has been particularly rewarding, because you can see how reluctant they were to look after their own leg or their relative's leg. But with the right support and resources, they've done a fabulous job, and you can see how empowered they feel. With self-care, there's what I'd call the reluctant self-carers. It's the patients who are only self-caring because of COVID, and they've made that really clear. And as soon as COVID has passed and they're able to get back to their practice nurse or hospital appointments, they certainly will be doing that. And that's fine. We just need to support them as best we can through this challenging time. So another advantage is that my colleagues and I have been asked to upskill redeployed staff. So this covers dentists, health visitors, school nurses, podiatrists, anyone who's been redeployed into the community neighbourhood teams who will be delivering some wound care. So this has been particularly rewarding. Some of the staff have been phenomenal. Some health visitors have just picked it up, and it's as if they've always worked in district nursing. They've been outstanding. There's other advantages really, because not to forget that these staff members are also members of the public. So post-COVID, they'll go back to dentistry, they'll go back to health visiting, school nursing, but they'll also take back those skills, that public health knowledge that they've gained from working in district nursing. So particularly around pressure ulcer prevention and leg care, leg health, general care of legs, the crucial role of compression hosiery, all these general health messages that these redeployed staff are learning, they can take them back with them post-COVID, take them back into the normal workplace, but also take them back to their friends and family and just help spread that public health message that we're always so desperate to get out. Other advantages is we've been upskilling non-registered staff in compression bandaging, which has been really well received, and we're delighted to have had that opportunity to do it really. We've also it's been a good opportunity for us to deliver bespoke training in small numbers in each neighbourhood team. So for example, some therapists, so occupational therapists and physios asked for bespoke pressure ulcer prevention training. And under business as usual, we wouldn't be able to have done that. There would be too many other work pressures to offer training for 4 or 5 people that we've designed just to fit their needs. But we've been able to deliver that during COVID, which has been really helpful. So some challenges, and there's plenty of challenges. As Nikki mentioned already, it's a big change, it's exhausting. It's a lot to take on board for a lot of staff. So as I mentioned already, some patients and families need a lot of support to self-care, whether that's just to start it or whether that's to be maintained. Some patients like a weekly phone call, they want to send pictures more regularly than they need, but it's whatever support we can provide them, just to empower them so that they can take some more ownership of their own problems, which hopefully will stay with them in the future and beyond. So a particular challenge is capturing the outcomes of all this change. It was thrust upon us. Nobody thought this would happen this time last year. So there's been so much change. It's a challenge just trying to capture the outcomes. So are these patients who are self-caring getting the same clinical outcomes as those who are receiving care from nursing staff? Are the patients who are receiving care from non-registered staff doing bandaging or the redeployed staff who are doing simple wound care, are the clinical outcomes the same? And we don't know. We're looking at ways of trying to capture that. It's all going to be retrospective, really, any kind of useful data we can capture, but I'm really keen to make sure we can try and capture some outcomes of all this change that is happening. Another challenge is that we've got reduced access to secondary care specialists. We've got excellent relationships with our secondary care specialists in Leeds, so we still have open communication with them, but understandably appointments are reduced. They're emergency appointments only. So we've been relying much more on email communications and remote assessments by secondary care with us as a in between. So, but that has been challenging. There are patients that we're starting to think now they're not urgent, but we would like them to be seen by secondary care. Another particular challenge is the neighbourhood team expectations. So people are different, we know that, and having a specialist within a community nursing team, for some staff that's been a fabulous learning opportunity and they've embraced it entirely and they're really developing. But for other staff, it can be difficult. They're so busy, and there is the risk that we're seen as a solution so that we can fix their problems for them, which is not what we want to do. We want to help them learn to fix their problems themselves. So it's just the expectation of the community teams that we would come and do all the work for them, which is understandable given the phenomenal pressure they're under. But it's trying to get as much learning opportunity in each of these opportunities, really. There's the question that are some staff being de-skilled by our presence? We're very accessible. They've got a specialist in the office most days, and we're very easy to grab and ask a question, but we have to try and structure how we speak to people so that we're trying to tease the answer out of them. So each conversation is a learning opportunity rather than just instruction. So another learning opportunity which is missing really is that really useful bedside learning, which you can do on joint visits with staff. There's no joint visits at the minute, and from my experience, the learning that staff members can have from a specialist service when they're with the patient in the house and problem solving together is invaluable and much more valuable than a PowerPoint presentation, for example. So that's something that is missing at the minute. So these, as Nikki's already mentioned, the Tissue Viability Society website is an excellent resource, but I have to mention the Legs Matter website. I must use this every day, and the patients who are self-caring and their relatives have found it really, really useful. There's a wealth of information on there just to help patients and their family members really grasp self-care, be empowered to look after their own legs and feet, and do that for the rest of for the future, really, because it's not something that we want them to hand back once COVID is over. It's something we really want to empower them and tell their friends, tell their families, spread the word about excellent leg care. So the Legs Matter website is a phenomenal resource.
Thank you, Kate. So Kate, you talked a little bit about some of the opportunities. What would you say has been the #1 opportunity that you've experienced during COVID-19 and your redeployment?
I think the obvious answer would be self-care, but the more I've reflected on this, I think the opportunity to get the public health message around leg care, leg health and fresh ulcer prevention out through the redeployed staff is an excellent opportunity. These are people we wouldn't normally reach through awareness weeks and awareness days. So dentistry and specialisms such as that, for them to really get a grasp of the public health message around pressure ulcer prevention and leg health is really, really useful.
Brilliant. Okay, thank you. Okay, so we've got a few questions. Are the clinic staff tested for COVID-19 routinely? And if so, how often? And this is a question from South Africa, from Trish. So do you want to answer that? Do you want me to answer it? I'll answer it. Okay. So thank you for your question, Trish. So in terms of COVID-19 testing, I don't know if you've watched very much of the news about the UK, but there's been a little bit of a delay really in the UK around testing. And so therefore what we've generally speaking been asked to do is only present for testing if we've got symptoms. So we're not routinely tested. Any staff that presented with any symptoms were self-isolating for 14 days and therefore wouldn't have seen patients. So that's the answer to that one. Hi Kate, do you think going forward that the integrated team working, I can't see the rest of your email, your message, Alison, but I'm presuming that you think that the integrated team working approach will carry on. What do you think, Kate?
I think well, within Leeds, we've already got integrated teams in the sense that there are occupational therapists, physios and nurses and social workers all together. So from our perspective, there is some integration there already, but certainly there's a wealth of work to be done. Specialisms such as podiatry within the base has been incredibly useful. And I think there's a lot of work which could be done around integration moving forward. And so more integration with primary care, more integration with the care homes and the secondary care sector. So for us, I think this is just the beginning really. So there's much more work we could do, which would be so beneficial to patients. We already established a virtual clinic with our local vascular team. And I think that we've had to disband it due to redeployment, but moving forward, things like that are going to help us integrate services much more effectively using IT as well as actual face-to-face appointments. But there's huge opportunities for integration.
Yeah, and I think from our point of view, there's sort of integrated work across primary care and the community trust has really sort of fostered the relationships that used to exist way back when between community nurses and their practice nursing colleagues. So I think that's been really beneficial. And the other thing that's been good that's come out of it is the use of one single template to capture data for the practice nurses and the community nurses. So, I think that's also going to be really helpful going forward. So thanks for your question, Alison. Okay, so Rohan has asked, are there any free apps available through which wound assessment, size and depth can be done through telemedicine during this COVID time?
We're not using apps as such. I'm sure that some of the companies will have developed apps. It's not something that we use in Leeds. We prefer not to use a company-sponsored app, if I'm entirely honest. But I know they are available. There'll be many companies that you could approach that would have apps. It's wherever you work, whatever your local IT policy or guidelines are, you'd have to work with your local area as to whether an app was compatible with your own documentation system. So I know they're out there, but I couldn't recommend one because we don't use them. We prefer not to use them.
One from Jamel. Hi, Kate and Nikki. Have you had any support from your local secondary care vascular care services working to keep people out of A&E, such as the homeless with leg ulcers?
We do. We've got a really good relationship with our vascular team in Leeds. We're very lucky. And they do a homeless clinic already. If I'm honest, I don't know what impact COVID has had on that. I know that my colleague in the vascular team in Leeds was doing a weekly clinic at one of the homeless shelters. Whether she's had to suspend that, I don't know. I suspect she may have, but it is certainly something that we will, that I suspect she will pick up moving forward. And for us, we've got such clear links with them through the virtual clinic that any kind of complex patients we can keep out of A&E, we do. So I'm not sure, if I'm honest, Jamel, what impact COVID has had on the clinic that Julia was doing with the homeless team.
Okay, and then I think this name was Selvan, but apologies if I've got your name incorrectly pronounced. So it says, hi Nikki, my question is, how risky patients with diabetic foot ulcers, if the patient's under quarantine, will the healing be hampered? Well, if patient, go on.
Yeah, I'd like to think not, to be honest. The diabetic foot team in Leeds Hospital are still seeing some patients. They have the criteria for being seen is obviously tighter due to COVID, but they are seeing the most urgent patients. But in addition to that, the community diabetic foot team will work very closely with the acute trust and will go out and assess patients. So I've had patients with diabetic foot ulcers who I would normally have sent into the secondary care clinic, but we've referred into secondary care and primary care, just so the patient is on a pathway. But the patients have been seen, the primary care podiatrists communicate with secondary care. So I'd like to think that there's been no detrimental effect to the patients within Leeds with diabetic foot problems, because processes have been put in place to make sure that they are assessed, whether it be at home or in an acute setting.
Thanks, Kate. So Anne asks us, was PPE worn as standard for you in the community? Also, were there any delays in referrals to GP vascular surgeons for patients in need of systemic antibiotics or debridement? So there's kind of two questions there. So PPE has been worn, hasn't it, as standard for us in the community, and we've been very much guided by the national recommendations. So as COVID risk has escalated and the need for greater protection has been needed, then we've responded accordingly, and we've been very fortunate in that we haven't had any lack of PPE equipment.
No,
in terms of delays to vascular first, systemic antibiotics or debridement, anything?
There's no. The vascular team will see urgent patients. So if a patient requires IV antibiotics, which is why someone might be sent into secondary care, they are accepted. There's been no delays. So vascular will see urgent patients. If a patient needs to be admitted for IV antibiotics, they are admitted for IV antibiotics. In the media, you'd see lots of things in patients. Ambulance aren't taking patients to hospital, patients aren't being admitted to hospital. We haven't experienced any of that. If a patient has needed urgent secondary care attention, they have received it. So it hasn't had any detrimental effect. It is difficult for the routine vascular referrals. So a patient of mine at the minute hasn't been seen by vascular. He's not urgent, he can wait. Under normal circumstances, he would have been seen by now. But for anyone who is urgent, they are still being seen. So we're confident that those patients with acute problems are attended to appropriately.
Thank you. And there's one here from Tina Chambers. Tina, hello, just found the way to ask a question. Great presentation, interesting. Thank you very much. Interesting that some patients will only accept self-care on a temporary basis. And changes into healthcare may mean that this is the way forward. Do you think they will accept this as business as usual?
I think in my mind, those patients, and I've only met a few to be fair, who are not enjoying self-care. They find it a struggle. They've made it very clear that they're only doing this because they don't want any clinicians in the house and they're shielding. So maybe we could talk them round, so to speak, but the numbers are small. They really are, compared to the numbers of patients who were reluctant, as I'd say at the beginning. Those patients are really embracing it now because they can see the results. I think the hesitance from those kind of patients, or more often than not family members, the hesitance was around confidence. They didn't feel they had the skills, they didn't feel they were knew what to look for, but with the right support, they've really embraced it. There's a patient of mine who he's quite a character, and his wife was so reluctant to take on his leg care, but with the right support and teaching them a little bit of IT, I've been able to support them weekly, and her confidence now is amazing, and they will certainly take self-care forward. He's got so many comorbidities, there's no need for him to be going to countless appointments in the future, even once COVID has passed. So for people like those, it's an absolute joy when you see that the confidence grow. They were so hesitant about it in the beginning, but they're confident, they can see the wound improving, they know they're able to do it. So for those people, it certainly will become business as usual in the future. But there is that small minority who are not enjoying it, and that's fine. People are different, so we can't win them all.
I think one of the things that I found the most useful is we're lucky in Leeds in that we have a role called self-management facilitator, which is a non-registered role. It's set at band 4 level, but their role within the neighbourhood teams has been very much to encourage patients to self-care. And we employed one just for 1 day a week in the integrated wound clinics because we're just testing the principle at the moment. So we just wanted to look at different models, and she has been absolutely fantastic. And I think a lot of patients do need that kind of support. So she's worked with a patient of ours who's had a diabetic wound on the malleolus for 5 years. He had uncontrolled diabetes and had tried, you know, sort of typical, I've tried everything, love, I've done all this, I've done that, I've done that. He's from Yorkshire, so she's worked with him, and he's 90, and she's got him weighing his carbs, so he knows exactly how many carbs he's eating. And she's only been seeing him for 5 weeks. He's got stable diabetes, and the leg ulcer that he's had for 5 years is virtually healed. So there are some amazing stories like that out there that I think, you know, without COVID-19 we wouldn't have experienced to some extent. And I think, Tina, you're right, I think it has to be the way forward. Next question from Linda. Thank you, Linda. Are there any plans for the redeployed staff to go back to their original roles, as there must be health visiting needs?
I don't know, if I'm entirely honest, Linda. I know the Trust are looking at each service that has been redeployed, and service by service they're going to look at who would be back in their previous role rather, before others. But I think I can't really speak for the health visitors, but for myself, for our team, it is a good opportunity just to stop and think about how we used to function, what we're learning from COVID, particularly around using IT to assess patients remotely. There's a lot of kind of rethinking. We don't want to just go back to business as usual, but I know some of the redeployed staff, the dentists particularly, are really looking forward to getting back to what they're trained to do.
Yeah.
So it's very challenging for these staff, but they've been phenomenal. They really have.
And what about you, Kate? Have you heard when it's likely that you'll go back
We
to?
don't know.
No.
No, there's conversations starting to happen, but it's more around taking the opportunity to look at what changes to our service can we make? What have we learned from COVID? What have we learned from being within the neighbourhood teams that we can use to improve wound care across Leeds for the future, really? But for us at the minute, we're still redeployed. So
Right, okay. So Linda's saying actually that their staff haven't been deployed into the community in Edinburgh, so that's quite interesting. So there will be some regional, national, international differences, won't there, to how organisations have responded. Hi, this is, I'm going to get this name wrong, I am so sorry. Grain, sorry, from Ireland. Grania. Thank you, Kate. I am. In relation to compression bandaging, which is our preferred method?
For self-care, we'd start teaching short stretch bandages, whichever brand, no preference. But short stretch bandaging is much easier to teach patients and families. It's quicker to learn, and so from our point of view, we've only been teaching family members short stretch compression. Some of the family members are phenomenal bandagers. One patient's daughter particularly has been watching nursing staff apply short stretch bandaging to her father for months now, and when I asked her if she'd like to do it, she just took the bandage and did it beautifully. She's been watching people do this for months. So as regards brands, there's no preference, but we would usually use a short stretch bandage to teach family members. It's just easier to learn.
Yeah, okay. I think the other thing as well, do you use the 2-layer hosiery system as well?
Yeah, we use the hosiery kits for the appropriate patients. The patient I was mentioned just now, where his wife was doing it, he's wearing a hosiery kit. It's perfect for him. So we'd assess the patient, decide, it's part of the assessment really, what compression is right for them and their ulcer, and then what can we teach the family member to apply, or apply it themselves in the case of hosiery.
Okay, and we've got a question here from Mohammed. So it says, is the operation theatre required for wound care of COVID positive patients? I suppose that's really going back to clinical need, isn't it?
Yeah.
If patients do require surgical intervention or debridement or, well, I suppose worst case scenario amputation, then, you know, patients, whether they're COVID positive or not, would be treated.
Yeah, if a patient's acutely unwell, they're treated, and if part of that is requiring surgery for whatever reason, then they will receive the surgery regardless of whether they're COVID positive or not.
Yeah. Now, I don't know if anyone else has got any questions out there. Please feel free to enter them. Just make sure that I haven't missed anybody's question. Oh, here. So Zoe, thank you for your question. Have you noticed an increase in pressure ulcers?
There has been an increase in pressure ulcers compared to this time last year. Whether that's entirely down to COVID, we honestly don't know yet. Some of the themes and trends are similar to the themes and trends we'd have usually. It's easy to say that it's related to COVID, but we don't know. I know from speaking to colleagues across the country, Some of my peers, they've also experienced increasing pressure ulcers, but others haven't equally. So I think there's so much learning to be had from this experience, that looking at things like pressure ulcer numbers during COVID, we need to tease out the real learning from each of those incidents really, and look at, did COVID really play a part in that patient developing a pressure ulcer or not? So it's going to be a lot of retrospective work and a lot of teasing out the particular themes and trends from each incident really. So, but on paper, yes, there has been an increase.
Thank you, that's really helpful. So just seen another question, which was around the use of IT, and so has any sort of IT methods been particularly useful during COVID?
I think this is one of the definite benefits of redeployment and COVID. So for our service now, there's 6 of us, 6 specialist nurses that cover Leeds community. So that's a population of around 800,000. So one of us is available each day to triage referrals that still come into the wound service. So the majority of those would be from nursing homes. So these are care homes where there's registered nurses working within them, where the district nurses wouldn't visit. Traditionally, we would have gone and assessed those patients in the nursing home, but we've not been able to do that. We've had to use technology. So the change was forced upon us, but it's a really beneficial change. Again, we need to capture the outcomes. It feels, anecdotally, it feels like a good change. We are following up these patients by phone and again using emails, photographs. So there doesn't seem to be a detrimental effect on clinical outcomes, but we need to measure it properly. We need to look at these patients retrospectively and just really see if there has been an effect on clinical outcomes. But certainly moving forward, the trust is looking at different IT systems, really advancing video technology so that we can assess patients either in their own home or within care homes, so that moving forward, we don't lose the momentum that we've gained because of COVID around using much more IT to assess more patients without physically being with them.
Yeah, and it'd be interesting, won't it, to see whether or not it's the absence of specialist intervention in the care homes is perceived by the care staff as yet another thing that they've lost during this sort of COVID-19 period. I mean, there's been so much focus, hasn't there, on the lack of PPE in certain care homes, and obviously the massive loss of life in care homes nationally, for probably many number of reasons. But I think it'd be really useful to capture going forward what that isolation might feel like, that you know, the fact you can't just get you know into the care home this week or whatever.
It's difficult because it's something we've wanted to do for a long time, using much more technology within nursing homes to assess the patients more quickly and without the time taken to go and physically be there. But there are those patients who still need to be seen. The technology is not going to be a complete replacement for us. For example, tomorrow I'm going to see a patient in a nursing home. We've done some remote assessments, we've done some remote treatments, but I need to see her. I need to see her and touch the skin and be in the same room as her. So we are trying as best we can to manage these nursing home patients remotely and using IT, but we need to acknowledge that there are some patients that we do actually physically need to go and see.
Okay, thanks. So Nimesh asks, how frequently are changes of bandages required?
It depends on the patient, it depends on the wound, it depends on the level of exudates. If we can, we'd leave it up to 7 days. So that would be what we'd be working towards. So as things improve and the patient doesn't need rebandaging and redressing as often, then we'd hope to slowly decrease the frequency of the visits to a maximum of 7 days. but it's very individual really. We do that on a patient by patient basis. There's no set regime for any condition really.
Yeah, thank you. So the NHS in Scotland, just saying that there's been, Linda's just saying that sometimes the remote assessment can be hampered by connection problems, buffering and not seeing the images properly. She says that she's seen lots of benefits as well. Do you think that's, is that something that you experience within a sort of a city like Leeds, or?
We've not experienced it, but we haven't used the video technology yet. We've been relying on photographs and emails and phone conversations. So time will tell, to be honest. We're certainly moving towards the video consultations, but whether we have the same problems as in Scotland, I don't know. We'll shall wait and see.
Yeah, watch this space. Oh, it's one of my colleagues, Julie. Julie says, how do you think the community service will look post-COVID?
Well, who knows? I think from a community, from an integrated team point of view, once we're back to business as usual, there'll still be the occupational therapists, the physios, the social workers, the community nursing team all together. I think there's new pathways being developed around frailty, which has been linked to the frail elderly COVID patients. But what will it look like? I just think time will tell. I think each service is going to be looking at its own role and what each individual service has learned from COVID, and what can they change about each individual area moving forward. Because the integration is the future. That's where we're going to go. It's just how we achieve that. But I think there's lots of reflection and lots of conversations to be had about what it would really look like in the future.
Yeah, I think if I had a magic wand, I think I'd hope that we maintain the levels of self-care that we've managed to achieve during this period, with that, you know, all important safety net that's required to make sure that, you know, patients don't slip through the net. I think, you know, the demand on the NHS, I hope people realise actually that it's not always necessary to go to A&E. You know, we've seen massive reductions in A&E attendances, and there's some concern about that from the point of view of, you know, are the right people going at the right time? But at the same time, I'm sure that the A&E have seen a reduction in the sort of unnecessary bumps and scrapes that could wait until a GP is available in the morning, kind of thing. So I hope that carries on. I just hope people are a lot more respectful of the NHS going forward. You know, it is not a finite, it is a finite resource. There is a finite resource associated with it. And, you know, and therefore we've got to treat it with respect. Okay, so I think the last question before we break is around, has there been an increase in the usage of negative pressure wound therapy devices during COVID?
I can't say that there has, to be honest. I think from my experience, it's pretty much unchanged. The majority, but not all, of our negative pressure would come from the acute trust. But for those patients, like diabetic foot patients, for example, if they still need surgery, then they still get surgery. These patients are not being operated on. So for us, I can't say that there's been any change in the amount of negative pressure that we've been using.
Thanks, Kate. Okay, so we've come to the end of our 45 minutes. It's passed really quickly. Thank you ever so much for taking part in this webinar and for all your questions. I've got a list of my own, but I didn't need them, so that's great. Don't forget that you'll be able to access the video recording of the webinar on demand via the EWMA webpage, which is www.ewma.org, and you can follow the link what we do to access the webinars. So thank you again. Stay safe, Some of the difficulties with the vision has been that Kate and I are trying to maintain social distancing whilst doing a webinar, which is a challenge in itself. But you stay safe and good night. Thank you.